Assalamu alaikum. Good evening, everybody. I am honored today to welcome you all in Diabetes Guideline Update webinar by Emirates Diabetes Society, sponsored by Novo Nordisk. Today, Diabetes Guideline Update webinar will be starting 7:30 now, and I appreciate your participation in this webinar, and I'm sure you will enjoy it, this scientific meeting and informative meeting with our local and international expert. Just for your kind information, this webinar will be live streamed on Emirates Diabetes Society channel and website. Also, if you have any question at the end of each session, please write it in Q&A box, and please mention the speaker's name next to your question, so it can be directed to the same speakers. And this seminar is accredited 3 points, CME points, and it will be available within 7 days after filling the evaluation form, which will be sent to your email, and answering the post-webinar quiz. For any assistance or support during the webinar, there is a live chat support on WhatsApp using this number 056 9944 287. And I'd like to introduce our first speaker, Dr. Sarah Suleiman. She's a consultant endocrinologist and clinical lead for the genetics of diabetes and endocrinology, Imperial College London Diabetes Centre, and she's honorary senior lecturer at Imperial College University in London, UK. Today, she will speak about the management of hyperglycemia and type 2 diabetes. Dr. Sarah, the floor is yours.
Thank you very much, Dr. Busana, for your very kind introduction. I'm honored to be speaking with you today on behalf of many of my colleagues. I'm particularly grateful to Dr. Fathia Al-Awadi, who not only started this initiative, but actually very nicely and gently led us all to complete in a timely manner. So my role is to speak to you about the management of hyperglycemia in type 2 diabetes, and I'll be focusing on the components of appropriate management, specifically looking at what constitutes a good structured education program, glucose monitoring and how we do that, lifestyle modification, and in my mind, what's the most important part of this session is the initial and follow-up assessment of patients with diabetes, so that patients, no matter where they're seen, receive similar appropriately high quality care. So as part of a diabetic patient being diagnosed, they should be offered structured education. They should be, whenever they're found, annually thereafter, to reinforce messages that we give them. If any complications arise, because then there'll be education that's related to that. During transition of care, particularly from pediatrics to adults. Intensification of treatment. So for example, if someone had been on diet alone and moves on to oral medications, or from oral medication to injectables, or from basal to basal bolus. The program, so we all write education given, but actually having a structured program can reduce HbA1c by up to 2%, as good as many medications. What does the program need to be a good quality program? It should have specific aims and learning objectives. It should be individualized. So if you have a young patient who's just been diagnosed, the complications bit is not so relevant, but the monitoring, and so you need to individualize it a bit. You need to have a structured curriculum that's theory-driven, evidence-based, that you can actually give them leaflets about so they can take away. It needs to have specific aims and learning objectives. It should provide support to the person and their family members in developing attitudes, beliefs, knowledge, and the skills to manage their diabetes. It should be quality assured and should be reviewed regularly as new data comes along. It should contain information on diabetes pathophysiology and treatment options, healthy eating, physical activity, medication and its usage, monitoring and using patient-generated health data, complications, how we prevent them, how we detect them, how we treat them, psychosocial issues, problem solving, and social aspects, very important, such as fasting Ramadan, driving, traveling with diabetes, particularly on patients for patients with insulin. We move on to monitoring, and I'd like to mention 2 bits of that. HbA1c is our major tool for assessing glycemic control in a clinical setting. So it's not so relevant for the patient's care for himself, but very important for us. It's a strong predictor of diabetes complications. It reflects glycemia over the preceding 3 months. However, it can be affected by red blood cell turnover. And my colleagues yesterday have discussed issues that can affect HbA1c turnover, such as hemoglobinopathies, which are relatively common in our region. It is recommended to have it every 3 months, or at least 2 to 4 times per year, it should say, rather than per month. Point of care testing can help guide timely treatment options. So if you're able to do an HbA1c on the same day of the visit, rather than review the HbA1c from the last visit, that helps you direct your treatment towards that patient. Monitoring of blood glucose is important for patients to evaluate the response to therapy and assess whether they're achieving their targets. It also helps guide our therapy and when we move up or scale down if a patient is developing hypoglycemia. The frequency and the timing of monitoring depends on the specific needs. So for example, if someone is on an oral hypoglycemic that does not cause hypoglycemia, monitoring 3 times a week should be absolutely fine, just to keep an eye out so that they do not become hyperglycemic for a long while without knowing. Whereas if someone is on, for example, basal bolus insulin or is pregnant and titrating their insulin, 4 to 6 times a day seems appropriate. It is important to measure the fasting glucose to rank up basal insulin. Education and support should be provided at the outset and during the annual assessments thereafter. And the things we look at are self-monitoring skills, what equipment to use, the frequency of testing, the interpretation of blood glucose results, because remember, this is us giving them a tool for their self-management, and actions that they take in response to their blood sugars. I'd then like to move on to lifestyle modification for people with diabetes, and this includes exercise. Patients with diabetes should be encouraged to walk for at least 150 minutes per week, as well as more strenuous exercise, more muscle building exercise, 2 to 3 sessions of resistance exercise per week. Having a good nutritionist who is able to assess the patient's diet and guide them individually, again, can have a significant impact on HbA1c, particularly at the outset of the disease, and should be part of the structured education program. We advise smoking cessation, and weight management is another key factor that we discuss in patients with type 2 diabetes. I just raised this number of 5%. The majority of people who are able to lose more than 5% of their weight can have a positive effect on not just the diabetes, but the lipids and the blood pressure. We will speak in slightly more detail about weight when we come to the tables. So we'll move on to the most important section, which is the initial and follow-up assessment of patients with diabetes, and that's split into 3 bits. The appropriate history we take, what examination we do, and what blood tests are appropriate at initiation of therapy when you first see them, annually, because that is a very important marker for lots of tests, but also the interim visits in the middle. So let's start off with a clinical history and things like hypoglycemia, hyperglycemia, hospitalization, factors that affect our management of diabetes should really be asked at every visit. Similarly, comorbidities such as blood pressure, cholesterol, we should at least ask about them at every visit, and symptoms of neuropathy, infections. Other things such as depression or history of thyroid disorders or malignancy are things that we have to ask about on an annual visit. But obviously, if a patient tells you during one of the periodic visits, then you would need to investigate a bit further. Other factors that we review on every visit include smoking, physical activity, eating patterns. One of the important questions we need to ask about is sleep disturbance. More and more we understand that patients with diabetes have a high risk of obstructive sleep apnea, and that managing that tends to improve glycemia as well as other risk factors. We should, at every visit, discuss compliance, medication side effects, particularly if you're initiating a new medicine, alternative therapies. We're in a region where many people use alternative therapies, some of which can interact with their medication. There's a good vaccination program, including annual influenza, 5-yearly pneumococcus, and hepatitis B as a one-off. As we discussed earlier, self-care of diabetes, including glucose monitoring, should be discussed at every visit. And ideally, if we're able, we would download their meter and review the data. Other factors related to self-care we can discuss on an annual basis. I would suggest, if you're able, to actually print out these tables if you do not see diabetes patients regularly, because it's actually quite helpful to remember what you need to do. So we'll move on to the physical examination. And as I suggested, we'll speak about weight. So for patients with a BMI of less than 28, with an ideal BMI, then we would encourage exercise, because exercise gives the health benefits, whether or not there is a weight issue. People with a BMI below 28%, we would recommend just a 5% weight loss. People with a BMI between 28 and 35, we should aim for a higher weight loss, 5 to 10%. And actually, with a BMI from 30 to less than 40, we should consider bariatric surgery if we're unable to achieve that weight loss. And with a BMI of over 40, we should encourage bariatric surgery. And weight really is one of the key measurements that we do at every visit. Similarly, blood pressure should be done at every visit, and orthostatic blood pressure at least annually. Moving on to other examinations, we look at the skin, particularly injection sites, annually, unless there is an issue with poor control in insulin-treated patients, when we can look more frequently. In someone with no retinopathy, retinal camera photography once a year is sufficient. However, if there is any abnormality, the rate is then dictated by an ophthalmologist. You would refer them to an ophthalmologist and they would dictate that. If you do not have access to a retinal camera, then as well as ophthalmoscopy, they should be referred to an ophthalmologist at least once every 2 years. Foot examination, we should be doing at least annually, but also at periodic visits, particularly in patients at risk of neuropathy, peripheral vascular disease, and actually when we assess for neuropathy, as well as a 10-gram monofilament, we would normally do at least one other sensory test, often vibration. And ABPI, or ankle brachial pressure index, is done in all patients above the age of 50, all patients who have diabetes for over 10 years, and patients who have diabetes and other risk factors such as cholesterol and hypertension at diagnosis. We would examine the cardiovascular system at least once a year with a physical examination, an ECG and an echo as required. We would examine the abdomen and the lower limbs again annually. Moving on to laboratory testing. Glucose and HbA1c, it goes without saying, we would have to assess at every visit that we see the patient, so long as they are regular periodic visits, i.e. once every 3 months. Can I just point out that below the tables, if you go to the actual article, below the tables, there's quite a lot of very useful information. So for example, the frequency of HbA1c is written, and the frequency of lipids is written at the very bottom. And it is agreed that 2 to 4 times a year, 2 times a year for someone who is stable on diet alone, really no issues. If you're monitoring them more regularly, if they're on medication, that might need altering. For cholesterol, what we've done is actually gone for the European Society of Cardiology guidelines and broken down people with diabetes into different groups according to their cardiovascular risk. So for those with a very high cardiac risk, and that will be discussed a little bit later by my colleagues, people who, for example, have the previous event, the target is to go for an LDL of below 1.4, those who are high risk, a target of less than 1.8, and those who are at moderate risk, less than 2.6, those who are at low risk, less than 3 millimoles per litre. So there's no absolute cutoff, but it's towards each patient. Triglycerides should be maintained below 2 millimoles per litre. Looking at renal function and electrolytes, we use an EGFR, and it seems fair to calculate an EGFR in all patients with diabetes, as that is what all treatment guidelines are based on, rather than a creatinine. EGFR of over 60 is taken as acceptable, and renal function really should be assessed annually and at periodic appointments. Annually, in people who do not have proteinuria, we would also measure an albumin-creatinine ratio, and a normal ratio in women is below 3.5 milligrams per millimole, and in men less than 2.5 milligrams per millimole, and if it is abnormal, on 2 separate occasions, they would require therapy and more frequent monitoring. Liver function tests in people who have normal liver function tests and no risk of fatty liver disease, no drugs that can affect it, we would recommend annually, but if there is any other reason, more frequent testing can be done. Vitamin B12 should be assessed annually for patients on metformin, as that can affect absorption. So in conclusion, type 2 diabetes is a chronic disease that requires lifelong management in a systematic manner to prevent long-term complications. The management of diabetes starts with education at the very beginning and throughout the management period. It includes access to a structured education program, key lifestyle advice, and advice on self-glucose monitoring. Monitoring of diabetes control by history, examination, and laboratory testing can be done in a structured manner to provide standardized care for all patients with type 2 diabetes in the UAE. Now, at the beginning, we should have had some questions, but I think what I'll do is actually go straight through to the question with their answers on, because we've missed out on them. So these are questions that were kindly put together by my colleague, Dr. Huda Ezzeddin. And the first one says, strategies for management of type 2 diabetes include the following, except the use of hypoglycemic agents, management of hypoglycemia, obviously a key thing in diabetes management, smoking cessation, monitoring of kidney function, and the DAPHNE program, dose adjustment for normal eating. And obviously the DAPHNE program is for type 1 diabetes, not type 2 diabetes, and therefore that is the incorrect answer. The next question is about the objectives of blood glucose monitoring. So the first one says to achieve an HbA1c of below 7%. As we said before, the HbA1c is a bit of a moving target. So for someone who's young and healthy, we would want an HbA1c as close to normal as possible, and certainly below 6.5%. For an elderly lady, we might want an HbA1c of 8% because she's at risk of hypoglycemia and lives alone. So that makes that incorrect. To reflect on the need and adequacy of therapy is the correct answer. To avoid glycemic variability. So blood glucose monitoring is not the most appropriate test for that. We would normally use continuous glucose monitoring or flash glucose monitoring to look at glycemic variability. Empower the patient to manage his own medications and avoid going to the attending physician. We don't really want patients to avoid coming to see us because, as we said, it's not just the blood sugar, it's everything else we need to look at. So all of the above necessarily becomes wrong. The next question, the right time to routinely ask diabetic patients. And as I said, I would suggest printing out these tables and maybe even laminating them if you need to. Hypoglycemia symptoms, we obviously need to check that every time we see the patient. Depression and anxiety twice a year, I think we'd said annual. The use of alternative therapies on their initial visit, actually because of the high use, we've suggested at every visit. Smoking status on their initial visit only, similarly, we've said at every visit. Medication compliance is on every visit, and I think that is actually a key question that we need to ask every single patient. And this is the final question. Which of the following is a correct statement about the examination of type 2 diabetes? An ankle brachial pressure index should be performed in all diabetic patients above the age of 40. I think it's 50. It can be younger if they've got other cardiovascular risk factors or have had diabetes for over 10 years. But 50 is the cutoff for a new diabetic. In a patient with no retinopathy, digital fundus examination should be done every 5 years. It should be done annually. Testing for peripheral neuropathy should be done annually using just a 10-gram monofilament, so that's incorrect. We've said that plus one other sensory test. The target level for LDL is below 1.8. It's a moving target again. If someone has very low risk, then it'll be below 3 millimoles. And if someone had very high risk, it'll be below 1.4, and there's a whole range in the middle. The recommended frequency of HbA1c testing is 2 to 4 times a year, and that is the correct answer. Thank you very much. Happy to take any questions.
Thank you, Dr. Sarah, for this valuable lecture. And I'm glad you mentioned the structured curriculum for patient care and monitoring and empowering patient and family in taking care of diabetic by self-care skills and education, which is very important for especially family physician in the primary healthcare centers. Now I'd like to introduce our second speaker, Dr. Alauddin Bashir. He's a consultant endocrinologist at Dubai Hospital, and he's the current president of the Sudanese Diabetes Association at Gulf Chapter. And he's a very active member of a research group and published more than 70 original papers and review articles. Today, he will talk about pharmacotherapy for type 2 diabetes in high-risk patients. Dr. Alauddin, the floor is yours.
Thank you very much, Dr. Busana. Supposed to discuss today the management of type 2 diabetes in high-risk group, and this is part of the actually the guidelines were developed by a committee that with many of the leading key opinion leaders in United Arab Emirates. And as I said, my task will be discussing the management of type 2 diabetes in high-risk group. Basically, before I start, I would like to stress on what Dr. Sarah just mentioned, that management of diabetes is not basically a pharmacotherapy. It's basically education and lifestyle management. These are the core of the management of diabetes, then followed by pharmacotherapy. And the management of diabetes pharmacotherapy in the current guideline is basically risk-based pharmacotherapy. So we don't just give the first medicine followed by the second one, then by the third one. We need to initially risk stratify our patients into different risk groups, whether they are very high risk, moderate, or low risk. And this risk stratification is basically followed the inclusion criteria in the cardiovascular outcome trials. So it's not something we just brought like that. It's basically, if you look at all cardiovascular outcome trials, the high-risk groups are basically were the patients who were involved in these trials. So we try to make it easier for people to understand. So to make it very easy for you, because this is the basis on which you're going to decide your management, it has a couple of questions that you need to ask yourself before you start managing your patient. So to go through that, I would like to share a case with you, and then we'll go through risk stratification and then decide what and how to treat the patient. So this is a 57 years old Emirati gentleman who is known to have type 2 diabetes for the last 2 years. So he is more than 50 and has diabetes for 2 years. He's also hypertensive for more than 10 years. He's known to have high cholesterol for the last 10 years, and he's on treatment. And he attended the clinic to you for management of diabetes. His blood sugar seems to be well controlled. However, recently he noticed an elevation in his self-monitoring of blood glucose readings. That's why he came and he attended the clinic. His blood pressure was found to be around 145/70. So you did some blood tests for this patient and you found that his hemoglobin A1C is 7.5%. His fasting blood glucose is a bit high of 135 milligram per deciliter. His random blood glucose is around 220. His total cholesterol 230 and his LDL is 90. His EGFR is 65 and is, as Dr. Sarah mentioned, an EGFR of above 60 is quite acceptable for us. So now, how do we risk stratify patients? Now, this is the patient. How would I risk stratify the patient? And to do that, I think you need to ask yourself 4 questions. The first question and most important question is, did your patient had any previous cardiovascular event? If the answer is yes, you don't need to ask any more questions. Your patient is a very high-risk patient. If the answer is no, the patient never had myocardial infarction, never had angio done before, he doesn't have peripheral vascular disease, he didn't have a stroke, then you need to ask yourself another 3 questions. The second question is my patient more than 50 years or less? And the third question is, how many risk factors does this patient have? And when we talk about risk factors, we don't just talk about hypertension and dyslipidemia. We talk about smoking, we talk about retinopathy and advanced retinopathy, not early retinopathy, because there was a bit of debate on whether to include just background retinopathy as a risk factors. Actually, there were some papers that support this, and with other papers support proliferative and more advanced retinopathy. So the second question is, how long is the duration? Or third question is, how long is the duration of diabetes? Is it less than 10 years or 10 years or more? So these were basically the 4 questions. I will repeat them. Did your patient have a previous cardiovascular event? Yes or no? If no, then you ask yourself another 3 questions. Is my patient more than 50? How long is the duration of diabetes? Is it less than 10 years or 10 years or more? And the third question is, how many risk factors does the patient has? And based on that, you can decide the risk category of your patient. So let's answer the first question. If your patient has a previous history of cardiovascular event, then he's a very high risk. You don't need to ask any more questions. Now, if the patient didn't have a previous history of cardiovascular disease, then you ask yourself, is he more than 50 or less than 50? And the second question is, how long is the duration of diabetes? Is it less than 10 years or 10 years or more? And the third question is the number of risk factors. Now, let's look at this patient. If your patient is more than 50 years, duration more than 10 years, he has more than 2 risk factors, is a very high risk. So as if he had a previous cardiovascular event. But if the patient is having type 2 diabetes and more than 50, and duration of diabetes is more than 10 years, however, no risk factors, no other risk factors, so this patient is a high risk. If the patient is more than 50, diabetes less than 10 years, and he has 2 risk factors, he's still high risk. And if your patient is less than 50, but duration of diabetes is more than 10 years, and he has more than 2 risk factors, he's also a high risk. So in summary, if you look at it, a patient more than 50 years and diabetes more than 10 years, he's either high or very high risk. You don't need to think much. If your patient is more than 50 years, duration of diabetes is less than 10 years, just ask one question. Does he have risk factors? If yes, he is a high risk also. So in general, most of the patients more than 50 years are high risk. And if we look at those less than 50 years, only if they have diabetes more than 10 years and having risk factors, they're considered high risk. Otherwise, patients are either moderate or low risk. And low risk is a very small group of patients with diabetes. Actually, some of the guidelines took out the low risk and they said almost all diabetic patients are either moderate, high, or very high risk. So based on that, let's apply this to our patient. So this patient is 57, so he's more than 50, and he has a diabetes less than 10 years. And in such case, he has to have risk factors. And this patient had other risk factors. He's also hypertensive. He is also having dyslipidemia. So more than 52 risk factors and duration of diabetes less than 10 years, then this patient is a high risk patient. So what is the recommendation for management pharmacologic therapy in patients with very high risk? If the patient had a previous cardiovascular event. Now, if he's already on metformin, then you need to add on top of that either a GLP-1 or an SGLT2, regardless of A1C. Now, here these medications are being given for more than one reason. They're being given to manage diabetes if the A1C is high. They're also given to modify and manage the cardiovascular risk in those patients. So a patient with diabetes, and if you can see in the table, it's written benefits regardless of A1C. So metformin, you add on top either a GLP-1 or an SGLT2. And if the A1C did not improve on either of them, then your second step is to add, if you started with a GLP-1, add SGLT2. If you started with an SGLT2, you add a GLP-1 as a third drug. And then you can move to other medications. You can add a basal insulin, you can intensify your injectable therapy, you can add other medications if possible. So this is the very high risk group. I'll take you back to my patient who is a high risk and not a very high risk. And this is the algorithm for management of high risk patients. If you look at high risk group, if the patient is already on metformin, we do prefer to consider either a GLP-1 or an SGLT2. Again, he's a high risk patient, either GLP-1 or an SGLT2, if resources permit. If resources doesn't permit, you can go and choose any of the other group of medications based on the requirement, whether you can add a basal insulin, a sulfonylurea, a TCD, or even a DPP-4 inhibitor. And then if the A1C is still above target, you can add another therapy. So for our patient, as I said, he's a high risk, and we have the option between a GLP-1 and SGLT2. So the question is, which one should I choose now? Should I go for a GLP-1 or an SGLT2? So the choice is basically dependent on a couple of factors. Number one, is my patient is just an ischemic heart disease or more of having a heart failure risk than an ischemic heart disease? Now, if the patient had an ischemic heart disease, without heart failure, GLP-1 is your choice. If the patient is having a heart failure, SGLT2 is your choice. Now, the eGFR, if the eGFR is below 45, you cannot use SGLT2. You have to choose a GLP-1. However, if your patient is having a renal impairment, extensive or proteinuria, then an SGLT2 is better than a GLP-1. So SGLT2 in cases of heart failure, in cases of high risk of renal disease, we use an SGLT2. If the patient is more of obese and having an ischemic heart disease risk, then that patient is for GLP-1. So this is the summary of the recommendations. We did recommend a risk-based pharmacotherapy for patients with with diabetes. And you can see the algorithms, it's going to guide you nicely to your choice of management. And as Dr. Sarah mentioned, there is a comprehensive checklist for periodic assessment of patients to see whether they're achieving their A1C level and whether they're achieving their A1C level, whether they're achieving a lipid targets or blood pressure targets. And with that, I end my presentation. Thank you for listening. And the mic is back to Dr. Buthaina.
Thank you, Dr. Ala, for your nice presentation and pressing more on the risk stratification in diabetes, which is a big issue in the medical field. Now we'll move to our third speaker, Dr. Mohammed Farouqi. He's the Director and Consultant Endocrinologist, Dubai Diabetes Center, and he's a lecturer at Harvard Medical School in Boston. Today he will talk about the pharmacotherapy for type 2 diabetes in moderate to low risk patients. Dr. Mohammed, the floor is yours.
Thank you very much, Madam Chairperson, for allowing me this opportunity to go ahead and be with the audience this evening. And I would like to thank Emirates Diabetes Society for allowing us this opportunity to go through the guidelines and Dr. Fathiya for her leadership. So I would also like to thank the nearly 1,000 participants who are here with us this evening, and they took their time to be with us. Generally, when these guidelines are published, they are sort of available for people, but Emirates Diabetes Society has made an effort to have these seminars so that we can also reach out and discuss this with the audience. So my previous two colleagues have gone through the first part, and now I am going to talk about the cardiovascular risk categorization, but in the moderate to low risk categories. So here, basically, as you recall from Dr. Ala, he has spoken about how to do the characterization in terms of the high risk. So in terms of how do we characterize low and moderate risk, basically, the most important thing is that whether the patient that you have in front of you does have cardiovascular disease or not. So for the person to be in the low or the moderate risk category, they need to be without cardiovascular disease, which, as you know, includes myocardial infarction, angina, having a stroke or something like that. Or in terms of target organ damage, they should not have target organ damage. And how do you classify somebody into having target organ damage? These are the individuals who either have proteinuria, renal impairment defined as a GFR below 60, left ventricular hypertrophy, moderate non-proliferative diabetic retinopathy, or advanced diabetic retinopathy. Now, at this point, it is very important to remember what Dr. Sarah Suleiman had said earlier on this evening, which is that we need to make sure that we are doing a thorough job in not only evaluating the people for their blood glucose levels and their hemoglobin A1Cs, but also in having them having an eye exam every year, having their renal status checked so that we can check for microalbuminuria, all the way down to proteinuria or their estimated GFR, so that we are in a position to categorize our patients more effectively. So if you have this particular categorization in mind, again, as my colleague Dr. Allah had mentioned, it is the age. If the age is above 50 and the duration of diabetes is less than 10 years, there is no or just one risk factor, it is a moderate risk. However, as you know, most of the patients that we would see would not have just one risk factor. And we'll talk about it more in a second. In the age below 50, we may have people who do not have had diabetes for more than 10 years. If they do, and they are without a risk factor or with a risk factor, then they are moderate risk. Less than 10 years duration of diabetes, greater than two risk factors, two or more than two risk factors, moderate risk, and no or one risk factor, they are in the low risk category. So this is the group that I'm going to talk about in the coming few minutes. Now, when we are looking at the real world population, what we do see is that 32%, more or less, of individuals with type 2 diabetes have established cardiovascular disease, which means that they have basically had a heart attack or a stroke, but overwhelming majority do not have a cardiovascular disease per se. So here is where we have to be very careful to look for any target organ damage, and we need to talk about the cardiovascular risk factors. So the normal patient that steps into our clinic is generally having not only diabetes, but they have hypertension, they have dyslipidemia, and on top, they do have a weight problem, and more likely, they are obese. So, when we are looking at our patient in terms of management of diabetes, obviously, none of us are just focused on isolated diabetes. We are focused on management of the whole patient in terms of their blood pressure monitoring and management of their dyslipidemia, and also how do we treat their obesity. So when we are going to go ahead and move to the addition of a second agent, then we have to have certain things in mind. So those things that we have outlined in the guidelines are efficacy, the risk of hypoglycemia, the impact on weight, and finally, the cost. But before we move on to the addition of the second agent and the fact that all of these things have to be considered, these patients generally are on metformin. And before we go into any of this, we need to also focus on two things. First, that they are on the maximum tolerated dose of metformin, and that they are having no major side effects from that. The second thing is, again, the importance of lifestyle modification, the diet and the physical activity. As I'm very fond of saying, the two legs that the management of diabetes stands upon is diet and exercise. We can prescribe any or all medications, but without that important intervention of lifestyle modification, none of these medications will work. So the next thing that we need to consider is the fact that we may not need to consider any of these agents if the hemoglobin A1C is already above 10. If the hemoglobin A1C for your individual patient is above 10, given that the maximum efficacy of any of these other classes except basal insulin is not going to help you get your patient to target, the guidelines recommend that if the A1C is above 10, kindly consider using insulin in this category. We now have a variety of different options in terms of basal insulin. Please choose whatever is appropriate. And the next discussion from Dr. Madani, we will be talking about the injectables. So I'm not going to go more in there. So we will then move back to the other 5 categories, and we are going to look at each one of them using the same criteria, which is efficacy, hypoglycemia, impact on weight, and cost. So with that, we move to the first one, which is the GLP-1 receptor agonist. Here, as you very well know, it is quite efficacious. The A1C lowering capability of the various GLP-1 receptor agonists is fairly high. In terms of hypoglycemia, we do not have a appreciable hypoglycemia risk with the GLP-1 receptor agonist. As you know, GLP-1 receptor agonists do cause some weight loss, and in the higher doses, they are in fact used as a weight loss medication. Unfortunately, here the cost is high. So that is a negative in a sense, if based on the buying power of the individual. But as far as efficacy is concerned, it is high. It has an impact on weight because most of the people, as we discussed earlier, are either obese or overweight, and there is no risk of hypoglycemia. The other important thing to remember is that the kidney functions are obviously important for any medications. However, with dulaglutide and semaglutide, we do not require any major changes in chronic renal failure. In the case of exenatide, if it is mild, we need to monitor, and moderate or above renal failure, it is not recommended. Lixazenatide, in severe, we have limited data, and similarly for other cases as well, liraglutide in end-stage renal disease or Saxenda, which is the higher dose, this experience, the real-world experience is still limited. So our recommendation is kindly refer to the prescribing information with regards to the renal function before you prescribe any of the GLP-1 receptor agonists along with metformin. The second category is of the DPP-4 inhibitors. As you know, there are multiple products out there in which you have a combination of metformin and a DPP-4 inhibitor. Here, our efficacy is intermediate. It's not as strong, but it's okay. The hypoglycemia risk, there isn't any significant hypoglycemia risk. It is weight neutral. The cost still is high, but as more and more generics are entering the market, we expect the cost to go down. Here again, please keep an eye on the renal function and the presence of congestive heart failure. Saxagliptin and alogliptin shouldn't be used in congestive heart failure. Linagliptin is okay to use in terms of impact on the renal function. If it is not that good, we don't have to worry about it in terms of linagliptin. And for the others, please look at the GFR, and you may need to cut the dose back down to half. So that again is about the DPP-4 inhibitors, and as I said already, it is in combination with metformin that is available in various formulations. Moving on to SGLT2 inhibitors. Now, later in the evening, we will have Dr. Lawrence Lai to talk to us about the cardiovascular outcome trials. But as we have spoken, as we have heard, that with the advent of the cardiovascular outcome trials that are out there now, what we do have is a large volume of data for the use of SGLT2 inhibitors in patients with cardiovascular disease. Here, as we have, these are moderate to low risk categories, so I'm not going to go into details about the high risk category, but again, the 4 criteria we talked about. Efficacy here is intermediate. Again, there is no risk of hypoglycemia. It does have some impact in terms of weight loss, but unfortunately, the cost is high. So if you have people, based on the data that we already have, SGLT2 is the preferred option in patients who already have heart failure or impaired renal function. Again, please refer to the prescribing information for the particular medicine you have in mind. Moving on to TCDs. Unfortunately, TCDs, as you know, have had quite a lot of bad press, and they are not one of our favorites anymore. But the issue is that still, TCDs are a class of agents, pretty much the only one that have demonstrated clinical improvement in indices of beta cell dysfunction, and they have the potential to improve beta cell function. So I don't think that we should write them off. We should be a little bit careful about how we prescribe them. Efficacy is high. The risk of hypoglycemia is not there. Unfortunately, as we all know, there is some weight gain when we use TCDs, and we don't need to use them in patients with congestive heart failure, as you well know. And now the cost is not that much of an impact. because it is now available in the lower cost category. So just to recap with the TCDs, that please avoid that in congestive heart failure. In terms of sulfonylureas, again, there has been a lot of debate about the use of sulfonylureas, but lately with trials such as ADVANCE, we do know that intensive glucose lowering in ADVANCE, we had a combination of metformin and sulfonylurea that reduced the risk of microvascular events, and the impact was similar when you used either sulfonylurea or a DPP-4. So again, in the real world analysis, we see that sulfonylureas and DPP-4 have a similar impact on cardiovascular outcomes. So given its high efficacy, and we do know that it brings down the A1C and causes hypoglycemia as well, unfortunately, it causes weight gain, but the cost is low. So do not leave sulfonylureas out of your armamentarium. Please think of how it would affect that particular patient that is sitting in front of you, and then make your choice accordingly. Finally, we have basal insulin. Now, in terms of basal insulin, as I said, multiple options are available, and I will leave to Dr. Madani, who is going to be our next speaker, to talk about the injectables. So here we are, in terms of a patient who came in to see you with just metformin, and you made sure that you had done a good thorough exam and look for any risk factors. Then you made sure that they were on lifestyle modifications. A1C was above the target, that was individualized for that patient. Now that is a different topic for a different day. How do we individualize the A1C, because one size does not fit all. After that, the A1C was below 10, so you chose one of these options. In 3 months, when you reevaluated the patient, the A1C was still above target. You then choose another agent, basically from the same lineup, to go ahead and make it a triple regime. The only thing that we need to remember here is that if the person is going to start on a GLP-1 at this point in time, we have to take the DPP-4 out of the combination line and use something else. So the same factors, which are efficacy, risk of hypoglycemia, impact on weight, and cost, would remain the guiding factors. Do not wait too long. Maybe another 3 to 6 months, A1C is still not where it is supposed to be. Please go ahead and initiate or intensify the injectable therapy. So with that, I would conclude my part of the discussion for this evening and hand it back to Madam Chairperson. Thank you very much for listening.
Thank you, Dr. Mohammed, for your good speech and scientific speech. Now we'll move to our well-known local expert speaker, Dr. Abdulrazak Madani. He's a consultant endocrinologist and diabetologist at Al Burj Medical Center, and he's the past president of Emirates Diabetes Society and the president of Gulf Group for Study of Diabetes. And he will talk today about the injectable therapy, initiate or intensify. Dr. Abdulrazak, the floor is yours.
Thank you, Dr. Butaina, for your very kind introduction. It says, Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. My colleagues, Dr. Ala and Dr. Muhammad Farouqi, spoke about the oral hypoglycemic agents in management of type 2 diabetes. And I'm going now to talk about the injectable therapy, when oral hypoglycemic agent alone cannot achieve the target glycemic control. As you know, it's discussion with the patient regarding having to start an injectable, it's not easy. The discussion is frustrating for both the physician and the patient. And it is important to know that patients with type 2 diabetes are scared about injecting themselves, and they are worried that their lifestyle will change forever because of the injection. And so they will try their best to, buy some more time by asking the doctor to give them one more chance. And we will try our best. We'll, do exercise. We'll, carry on a good diet control and so on. And it is so it is care from the injection itself, there's care from the needle, there's care from hypoglycemia, and also they always think that once they reach the injection, it means that it is the end stage in the fight with diabetes. So you have to convince the person who have diabetes, telling him about the benefits of going into an injectable and talking about, the benefits of the injections and the myth attached mainly to the insulin. And the main 2 points is the hypoglycemia and increase in weight. The ADA is the consensus of 2018. They say that GLP-1 agonists are considered the first choice before insulin when we are starting adding injection to the oral therapy. And they recommended that you consider GLP-1 receptor agonist the most prior to insulin. If the A1C is above target still, then we'll add basal insulin. Or if the patient is already on GLP-1 receptor agonist, or if GLP-1 receptor agonist is not appropriate or insulin is preferred. For example, patients with a poor renal function, or patients who have A1C over 11%, or those patients who have weight loss, remarkable weight loss. In these patients, we prefer to start with basal insulin rather than GLP-1 receptor agonist. And when we are putting the goal, the A1C goal and the glycemic target for our patients, we have to look into this slide, which I'm sure many of you are quite well aware about it. Those patients who should be more stringent in achieving the goal and putting the goal, and those patients who we should be less stringent than that. So always look at the attitude of the patient. If he is really, motivated and adherent and has excellent self-care capacity, then we should go for more stringent. And if the patient has no risk of hypoglycemia or other adverse effect of insulin, then we should also go for for more stringent goal. And if the newly diagnosed patient or the life expectancy of the patient is long in young patients, for example, or he has no comorbidities and has no vascular complications, in this patient, we should go for more stringent and put the A1C below 6.5%. But otherwise, if the patient, is not motivated, if he has a risk of hypoglycemia, for example, or any adverse effect of the medicine, if he has been diabetic for many years and the life expectancy is short, an elderly patient, and he has comorbidities and established vascular complications, we should go for this stringent diabetic target. My colleague, Dr. Mohammed Farouqi, spoke about GLP-1 receptor agonists, so I'm going to concentrate more on the insulin. In the page, we are going to start the basal insulin with one dose, that is in the evening, and the basal insulin is not enough alone, or we did not achieve the glycemic target we are looking for. Then we can add one mealtime pre-meal insulin, rapid-acting insulin, or we can shift to pre-mix the insulin twice daily. And in these two methods, if we did not achieve our target of glycemic control, then we can go to the basal insulin plus 2 or even 3 pre-meal injections of short-acting insulin. Now I'm going to present this case. This is a 52-year-old man who has diabetes for the last 7 years, and the review of his logbook showed that his fasting plasma glucose ranged between 9.9 to 16.3 millimole per liter, which is 178 to 293 milligram per deciliter over the past 2 months. His weight is 89 kilogram. His blood pressure is 135 over 85 millimeter mercury. His current treatment is Damicron MR 60 milligram twice daily, Januvia 100 milligram once daily, and Synjardy 10 over 850 milligram twice daily. In the lab, showed his fast blood glucose of 10.4 millimole, which is 187 milligram, and his 2 hours postprandial was 14.7 millimole, which equals to 265 milligram. His HbA1c was 9.4%. So the question is, what would be the next step in therapy for this patient? A, no change to therapy, just monitor the A1C again in 3 months. B, to add an additional oral agent, TCD for example. C, to add a basal insulin at bedtime. D, to stop glipizide, begin a premixed insulin analog therapy. And E, to stop all the orals and start basal bolus insulin therapy. So the question is for you. Okay, well, I see that the majority of you have, selected the right answer to add a basal insulin at bedtime. And that is almost 60% of you have selected that answer, and that is correct. So how to titrate the basal insulin? In the American Diabetes Association 217, they advise to start at 10 units per day initially, and then increase 2 to 4 units once or twice per week until fasting plasma glucose target is reached. In the American Association of Clinical Endocrinologists 2017 guideline, they say if A1C is less than 8%, start at 0.1 to 0.2 units per kilogram body weight. And if A1C is over 8%, start at 0.2 to 0.3 units per kilogram body weight, and then increase by 2 units every 2 to 3 days until fasting plasma glucose target is reached. The Canadian Diabetes Association advised to start at 10 units at bedtime, then increase 1 unit until fasting plasma glucose target is reached. Our fasting plasma glucose target should be between 100 to 140 milligram per deciliter, and postprandial target should be less than 180 milligram per deciliter. And then we have to choose always the simplest approach for the patient. When we look at the simplest approach, start with the basal insulin using a pen device to simplify dosing and injection. Many patients are scared of the needle. So when you show them the needle with the pen, the very, very small and thin needle, they may be more convinced to take the injection, because always they think of that, long needle that is used with the normal syringe. So demonstrate the injection at the visit and reinforce the target if they have no risk factors to be less than 6.5%, and set a target of fasting plasma glucose of less than 140 milligram per deciliter, and then instruct them to titrate the basal insulin by 2 units with self-monitoring blood glucose, fasting plasma glucose, and 2 hour post-meal once each day. And also establish a check-in schedule to report the self-monitoring blood glucose and involve the team. The diabetes educator and nutritionist are here to support you and to support the patient to adhere to the therapy and also to change his lifestyle to a better and more healthy lifestyle. And of course, one important point is to advise the patient, if he's a smoker, to stop smoking. If you are going to start the therapy with pre-mixed insulin, start always with low dose and increase gradually. If he's an insulin-naive patient, start at 10 units subcutaneously before breakfast and evening meals, 2 doses. And he's already in 1 daily insulin. Calculate the total daily dose he's taking and divide it by 2, and then get half before breakfast and half before evening meal. The oral diabetes, we can recommend always at least metformin, 1 to 1.5 grams per day in divided doses, plus other oral hypoglycemic if he's taking, but sulfonylurea has to be stopped. The blood glucose measurement is important to monitor pre-breakfast, the fasting, and pre-evening meal, the blood glucose every 3-4 days. Now we have a second patient. This is Mr. Yusuf, who is a 65-year-old male, comes in for regular appointment with his doctor. His father and 2 brothers have type 2 diabetes. He has been diagnosed with type 2 diabetes 11 years ago. He has a history of myocardial infarction 6 years ago with congestive heart failure. His HbA1c improved from 8.1% to 7.5% on basal insulin and was doing well until 3 months back. Now his HbA1c has increased again to 8%. He hates to measure his blood glucose, but agreed to bring self-monitoring blood glucose data reluctantly. Postprandial blood glucose is not controlled. His concern is about hypoglycemia. His medication, he takes Janomet, 50/1000 twice daily, Amaryl 4 milligram daily, and Jardiance 25 milligram daily, and insulin glargine 48 units for the last 2 years. Other medication includes Zocor 40 milligram for hypercholesterolemia and Codiavan 160/12.5 milligram daily for hypertension. So the question is, what would be the next step in therapy for this patient? No change to therapy, monitor HbA1c again in 3 months, increase the basal insulin at bedtime, add a prandial insulin, stop Amaryl, begin a premixed insulin analog therapy, or stop orals and start basal bolus insulin therapy. Question is for you. Well, both C and D are correct. I see that the majority of you, has gone for D, which is 32%, and C is also correct to add prandial insulin. So C and D, both answers are correct, and the majority of you, if you look, the more than 60% of you have chosen the right answer. That's excellent. So when is the appropriate time to initiate mealtime insulin? According to the joint position statement from the American Diabetes Association and the European Association for the Study of Diabetes, in those patients who are on basal insulin with 1 or more oral agent, whose diabetes remains uncontrolled, the addition of mealtime insulin should be considered. So how to add the prandial insulin? The patient records their blood glucose reading and then self-adjust their prandial insulin based on the reading. Patient begin titration by adding mealtime injection at breakfast. So we have to look at the pre-meal, pre-breakfast reading, which is the fasting reading. As we said, our goal is to be between 110 to 130, to 140. If the patient is within the meal, within the range, we should not change anything. We should not add any more insulin to that. If he's above the range, we'll add 1 unit. But if he's below the range, we'll reduce 1 unit. And if he's getting severe hypoglycemia, we'll reduce the pre-meal dose by 2 units. That's how we do it. We had start, as I said, with 4 units initially, and then we titrate it according to the fasting blood sugar. When we have additional dosage, when we reach the target, the pre-lunch target with the pre-meal or pre-breakfast short-acting insulin in addition to the basal insulin, then we look at the lunch and at the dinner. The same way, we'll start 4 units at the lunch, and then we, according to the blood sugar, we achieve it pre the dinner. If his blood sugar is within the target, we don't add. If his blood sugar is above the target, we add 1 unit. If his blood sugar is below the target or going into hypoglycemia, then we reduce by 1 or 2 units. The same we'll do with the pre-dinner short-acting insulin. Now we look at the algorithm of the Emirates Diabetes Society guidelines and to initiate or intensify the injectable therapy. If the HbA1c is less than 2% of the upper limit of normal, we look at the BMI of the patient. If the patient is underweight, then we'll add basal insulin. But if the patient is overweight, over 25, BMI over 25, then we'll start with GLP-1 receptor agonist. If his HbA1c is more than 2% of the upper limit of normal, then also we look at the BMI of the patient. If the BMI is below 25, we'll add the GLP-1 to the basal insulin. And if his BMI is more than 25, we'll give him the mixed insulin, or we'll shift to basal bolus insulin. And then if he did not achieve the A1C goal and the target, then we'll increase the dose of insulin, intensify it, having the basal plus the pre-meal insulin, and if not achieve the goal, then finally we go to basal bolus regime. And with this slide, I say thank you very much.
Thank you, Dr. Madani, for this valuable speech and giving us a clear vision about insulin and how to use it and how to titrate the doses. Now we'll move to I would like to welcome our guest of honor, Professor Lawrence Litter. He's the director of the Lipid Clinic, Associate Director of the Clinical Nutrition and Risk Factor Modification Center, and Associate Scientist in the Lita Shing Knowledge Institute of St. Michael's Hospital in Toronto. Dr. Litter is the past president of the Canadian Society of Endocrinology and Metabolism and is past chair of the Clinical and Scientific Section of the Canadian Diabetes Association. Today, he will give us a speech and talk about the impact of cobots on clinical decision-making in type 2 diabetes. Dr. Lawrence, the floor is yours.
Great. So thank you very much for the kind introduction, and I'm very honored Sorry. Okay, sorry. So thank you for the very kind introduction, and I'm very honored to be able to join you today and join this very important symposium. And I'd certainly like to, at the start, congratulate you on your very impressive and carefully thought out new guidelines. So what I've been asked to discuss with you this evening is the impact of cardiovascular outcome trials on clinical decision-making in type 2 diabetes. And here are my disclosures. I've worked with various diabetes companies, and I've always also been fortunate to be involved in many of these large outcome trials that I'll be discussing with you today. You're all aware that cardiovascular disease remains increased in our patients with type 2 diabetes. Here you see data from the Swedish National Diabetes Register, people without diabetes in black, with diabetes in orange. And you can see that although rates of mortality have been declining over the last 20 years, they remain about twice as high in our patients with diabetes versus the general population. And this was the cardiologist's view of our old-fashioned type 2 diabetes treatment. This is a slide borrowed by Professor McMurray, who many of you will know, a known, very renowned trialist. And this was this tombstone in loving memory of John Smith, died from heart failure, but had a normal hemoglobin A1C. And until a few years ago, this is the way the cardiologist looked at us, is that we were just focused on glucose and were not focused on cardiovascular risk reduction. But of course, since the FDA guidance in 2008, we now have 19 completed cardiovascular outcome trials with different anti-hyperglycemic agents in patients with diabetes, with a number of other trials expected to report over the next few years. So let me briefly review the results of these trials with you. DPP-4 inhibitors, at this point, we have 4 completed trials of various DPP-4 inhibitors versus placebo. Remarkable consistency. They all demonstrated cardiovascular safety, but no superiority. There was this unexpected increased risk of heart failure seen in the SAVOR trial with saxagliptin. And again, I was involved in this trial, and still 5 years later, we do not have a good explanation as to why we saw this increased risk of heart failure with saxagliptin. With the SGLT2 inhibitors, we now have 4 completed cardiovascular outcome trials. EMPA-REG with empagliflozin, CANVAS with canagliflozin, DECLARE with dapagliflozin, and VERTIS-CV with ertugliflozin. And the significant results are highlighted in green. You can see reduction in major adverse cardiovascular events, or MACE, were seen in EMPA-REG and CANVAS, 14% relative risk reductions. CV mortality was only reduced in EMPA-REG outcome, with the most consistent results being with regards to risk of heart failure, about a 30 to 35% risk reduction observed in each of these trials. Here you see one of now many meta-analyses of these various trials. And importantly, when you divide the results in those patients with a history of atherosclerotic cardiovascular disease on the top panel, no ASCVD on the bottom panel, You see significant risk reduction in people with prior history of heart disease, no benefit in those without prior heart disease, with the exception of credence, which of course was a different population. This was a renal population. And speaking of renal populations, we now have 2 studies showing benefits. So originally credence with canagliflozin. More recently, we have the results of DAPA-CKD with dapagliflozin. And both of these trials showing both renal and cardiovascular benefits in patients with impaired renal function and albuminuria. I know there has been a tendency to use these drugs in patients with kidney disease, even amongst those who do not have albuminuria, but I think it's important to note that where we have the best evidence is in patients with chronic kidney disease, including albuminuria. We also now have 2 studies showing benefits of SGLT2 inhibitors in patients with heart failure with reduced ejection fraction, the DAPA heart failure with dapagliflozin, more recently EMPEROR reduced with empagliflozin. They both had a primary endpoint of first hospitalization for heart failure or CV death. And as you can see here, not only virtually identical hazard ratios, even the confidence intervals were remarkably consistent across these 2 trials. Also importantly, these studies included patients with and without diabetes, and similar benefit both in those patients with and without diabetes. There are a number of ongoing trials in patients with HFpEF, in patients with heart failure with preserved ejection fraction. We do not yet have any data in this very common population in our patients with diabetes. So now let's move to the GLP-1 receptor agonists. And of course, we have the exendin-based GLP-1s, exenatide and lixisenatide, which only have about 50% homology to human GLP. And we have the so-called human GLP-1 analogs, which have 90 to 98% homology to human GLP. And I think it's important to highlight that these studies were done in somewhat different populations. Certainly the biggest difference is the percentage of patients with established cardiovascular disease. Rewind with dulaglutide, 69% of patients did not have established CVD. But I'd like to remind you that in the studies with liraglutide in LEADER and SUSTAIN-6 and PIONEER-6 with semaglutide, there were also primary prevention patients, although not as many as included in Rewind. And if we look at a meta-analysis with the GLP-1 RA trials, if we look at 3-component MACE, we see a fair amount of heterogeneity. Overall, a significant 12% risk reduction, but this benefit was seen in LEADER with liraglutide, SUSTAIN-6 with semaglutide, Harmony Outcomes with albiglutide, which is no longer marketed, Rewind with dulaglutide. PIONEER-6 had a numerical reduction in MACE. This did not reach significance, but recognize this was a relatively small study and was underpowered. In terms of cardiovascular death, overall a 12% relative risk reduction. This was reduced significantly only in the LEADER trial with liraglutide and Pioneer 6 with oral semaglutide. If we look at fatal or non-fatal MI, overall significant 9% reduction. Fatal or non-fatal stroke, interestingly, appear to be reduced to a greater degree with the GLP-1 receptor agonists, overall a 16% relative risk reduction. And if we look at a meta-analysis, the meta-analysis looking at the subgroups, in general, there was consistent benefit, but importantly, so if we look at established CVD or not, there was numerically greater benefit seen in those without benefit seen in those with established CVD, but this was not a significant interaction. The only interaction which was borderline significant was whether the drug was a human GLP homolog or not. So less benefit was seen in the exendin-based trials, that is lixisenatide or exenatide, than with the other GLP-1 receptor agonists. In terms of all-cause mortality, overall reduced by significant 12%. Hospital admission for heart failure, again, people talk about the SGLT2 inhibitors reducing the risk for heart failure, but if you look at the meta-analysis, GLP-1 receptor agonists also overall reduced risk of heart failure, but to a lesser degree, a significant 9% reduction. If we look at renal outcomes, composite kidney outcomes, including macroalbuminuria, overall reduced by 17%. If we exclude macroalbuminuria and just look at worsening kidney failure, a borderline significant 13% reduction. So certainly greater benefit with the SGLT2 inhibitors, but there is some benefit with the GLP-1 receptor agonists as well. In terms of safety, the other important reason to do these large trials, as you would expect, there was an increase in gastrointestinal side effects, nausea, less commonly vomiting or diarrhea, but rarely leading to treatment discontinuation. An increase in retinopathy was seen in the SUSTAIN-6 trial with semaglutide. This was seen only in the patients with baseline retinopathy who had a rapid and dramatic drop in their A1C. This has not been seen in any of the other trials. Importantly, no increased risk for pancreatitis, pancreatic cancer, or medullary cancer of the thyroid was seen in these trials. Now, I'd like to show you some newer data that came out at the recent EASD and ESC meetings that you may be less familiar with, but I think relevant to our discussions. Here is an analysis done by my colleague in Toronto, Dr. Subodh Verma, looking at the LEADER and SUSTAIN-6 trials, whether patients had a history of PAD or not. So you see the results for LEADER on the left, SUSTAIN-6 on the right, and you can see those patients with PAD in the blue lines, those without in the gray lines. And in both of these studies, as you would expect, the patients with peripheral arterial disease had increased risk of an adverse event, and the relative risk reduction, and especially the absolute risk reduction, was greater in our patients with peripheral arterial disease. And I think in practice, often people don't appreciate the very high risk of these PAD patients and the importance of addressing their risk factors in an aggressive fashion and of using drugs shown to achieve benefit. Here's another study. I mentioned earlier that the GLP-1 receptor agonists may have particular benefit on stroke. Here's a post hoc analysis of LEADER with liraglutide, SUSTAIN 6 with sub-Q semaglutide, PIONEER 6 with oral semaglutide, and overall you see these drugs resulting in a significant 18% relative risk reduction in risk for stroke. In terms of how do the GLP-1s achieve this benefit? Well, if we look at the mediation analyses, it's in general not related to traditional risk factors. The majority of the benefit appears to be related to direct effects of GLP-1 on the heart and on the vasculature. Here again is a study we presented at the EASD a few weeks ago. We did a meta-analysis of the renal protection with semaglutide and liraglutide based on the results from SUSTAIN 6 and LEADER. So overall in these trials, the risk of a renal event was reduced by 22 to 36%. And we found that hemoglobin A1C was estimated to mediate approximately a quarter of the benefit, blood pressure 9 to 22%, body weight up to 9%, but again, most of the benefit appeared to be unrelated to the effects of these drugs on traditional risk factors. Now, here's another study presented at the EASD, and they looked at the benefit. So they looked at the benefit of adding semaglutide to standard of care based on our completed outcome trials. And here you see the number of cardiovascular disease-free life year gains, years gained with the addition of semaglutide. And you see on the left, in patients with established CVD, there was some fairly broad estimate, but a mean increase of 1.7 extra years being CVD free. The largest benefit seen in the patients with the highest baseline risk of CVD. But even in those patients without established CVD, as seen on the right hand of the panel, again, some additional cardiovascular disease-free life years gained. So that is the evidence. How are we doing? And to me, a real eye-opener were the results of the CAPTURE trial, which was also presented at the EASD. So this is a very recent snapshot of the prevalence of cardiovascular disease in adults with type 2 diabetes across 13 countries. This was conducted in all the regions of the world, including Saudi Arabia. And overall, here you see the prevalence of these various cardiovascular outcomes, whether they be coronary disease, carotid disease, stroke, heart failure, arrhythmia, peripheral arterial disease, or aortic disease. But what they found overall, approximately 1 in 3 adults attending a primary or specialist healthcare visit had established cardiovascular disease. So these results, not very surprising, maybe slightly higher prevalence than some previous studies. But I think what was the real eye-opener Here you see the use of anti-hyperglycemic agents with demonstrated cardiovascular benefit amongst these patients. So purple are GLP-1 receptor agonists, green SGLT2 inhibitors, and red is either and a GLP-1 receptor agonist or SGLT2 inhibitor. So overall, only 22% of our patients were receiving one of these evidence-based therapies. But the real shock to me was that there was no difference in those patients with established CVD, seen in the middle panel, and those with no CVD, shown on the right. So even though we've had years of new trials and repeated guidelines saying that especially in the patients with established CVD, we should be using these evidence-based therapies. In real world, not enough of our patients are receiving these therapies. So in terms of guidelines, you're familiar with the American Diabetes Association guidelines, which highlight that in patients with who are either at high risk or established ASCVD, CKD, or heart failure, important, consider independently of baseline A1C or individualized A1C target. If ASCVD predominates, they give priority to GLP-1 receptor agonists with proven CV benefit or an SGLT2 inhibitor with proven CV benefit. If heart failure or chronic kidney disease predominates, priority to SGLT2 inhibitor or in addition, a GLP-1 receptor agonist. In the rest of the patients, individualize the drugs based on need to minimize hypoglycemia, minimize weight gain, or promote weight loss. And if cost is an issue, use a sulfonylurea or thiazolidinedione. The European Society of Cardiology guidelines, fairly similar. The major difference, and certainly we can discuss this, is if you look on the extreme left, in patients with type 2 diabetes who are drug naive, who have ASCVD or at high risk for ASCVD, they say you can go directly to an SGLT2 inhibitor or GLP-1 receptor agonist. That is, you don't have to go to metformin first. Finally, I just want to show you again a recent publication. Here's the American College of Cardiology expert consensus decision pathway on novel therapies for cardiovascular risk reduction in patients with type 2 diabetes. Certainly a focus on comprehensive cardiovascular risk reduction. They emphasize that one should screen for type 2 diabetes in patients with or at high risk of CVD. In those patients with diabetes, one should be aggressively treating cardiovascular risk factors and, of course, incorporating newer glucose-lowering agents with evidence for improving cardiovascular outcomes into clinical practice. And so again, this is, they say, in patients 18 years and older with type 2 diabetes and at least one of the following. So ASCVD, heart failure, diabetic kidney disease, or at high risk for ASCVD. So very broad population that they define, and they say address concurrently both on the, as you can see on the left, guideline-directed medical therapy for prevention. So of course, lifestyle, blood pressure, lipids, glucose, antiplatelets. But in addition, and again, address concurrently, recommend starting an SGLT2 inhibitor or GLP-1 receptor agonist with proven CV benefit. They suggest that one discuss patient-clinician preferences and priorities, and then decide whether to choose an SGLT2 inhibitor, a GLP-1 receptor agonist, or no action for whatever reason. And specifically with regards to GLP-1 receptor agonist, they say do not use if patient is pregnant or breastfeeding. But as you work your way down through this, what they recommend is a GLP-1RA with proven ASCVD benefits, so dulaglutide, liraglutide, or injectable semaglutide is appropriate. Start at the lowest dose, follow labeling instruction, etc. So it gets very complicated. This is an algorithm that, again, one of my colleagues in Toronto, Dr. Alice Cheng, put out. And what she suggested is that we select based on the most prominent feature. So in patients with clinical CVD, add an SGLT2 inhibitor or GLP-1 receptor agonist, and if necessary, add the other. Patients with chronic kidney disease, preference to SGLT2 inhibitor. HFrEF, preference to an SGLT2 inhibitor. Risk factors, preference to the GLP-1 receptor agonist or SGLT2 inhibitor. However, in your frail patient or patients with no risk factors, one would either add a DPP-4 inhibitor or individualize. The one thing that is not on this algorithm that I would add is that in our very frequent patients in whom weight loss is necessary, again, I would suggest preference to GLP-1 receptor agonist. So bottom line, we have come a very long way. The management of type 2 diabetes has evolved. We've moved in a relatively short period of time from managing glucose to the use of novel agents that can dramatically reduce the risk of the major comorbidities of diabetes: atherosclerotic cardiovascular disease, heart failure, and diabetic kidney disease. So thank you again for the opportunity to join you today, and I look forward to our panel discussion.
Thank you, Professor Lawrence Litter, for this valuable presentation, and you give us a clear insight about the cardiovascular trial and the use of other medication. Now we'll go to our question and answer. First question was, I think, to Dr. Sarah. And diabetic patient diagnosed with a peripheral neuropathy, what is the percentage of having other complications?
So diabetic neuropathy is just an indication of microvascular disease. And I cannot give you an actual figure. However, one would imagine that there is nothing special about nerves. Evidence of other microvascular disease, such as retinopathy or nephropathy, is relatively common in patients with peripheral neuropathy. That's probably the best I can do.
And there is one more question to you, Dr. Sarah. How COVID-19 impact the diabetes type 2 patients?
Yeah, I saw that. I've answered about 12 or 15 questions, and I left the ones that I thought I needed to think about. So this is an entire lecture. People with diabetes are affected worse by COVID-19. It's probably related to glycemia per se, rather than diabetes. COVID-19 goes into cells through the ACE receptor. That's actually overexpressed in diabetics. People with diabetes who do contract COVID-19 get severe insulin resistance. They require large doses of insulin. Even type 2s get ketoacidosis. So it's not a good combination. It's reasonable advice to try and keep our patients with diabetes away from places they might contract COVID-19, in summary.
Okay. Thank you, Dr. Sarah. Dr. Ala, they are asking, what about using aspirin for diabetic patients?
Well, this is part of managing other risk factors. Patients with diabetes are generally high risk. Very high risk and high risk. Very high risk are patients already who had atherosclerotic cardiovascular disease, and aspirin is indicated in those patients. High risk, then you need to weigh the risk and benefits, and most of them more than 50 and high risk, most likely they would require to be started on aspirin.
Yeah. And they're asking, is vitamin B12 more than 1,000 in diabetic patient considered a risk factor?
For
diabetic patient, just as mentioned.
I mean, a risk factor for cardiovascular disease? Generally, patients with diabetes, especially those on metformin, we, as Dr. Sarah mentioned, they would require actually monitoring of B12 level frequently because they might have reduction in vitamin B12 level or vitamin B12 deficiency. And however, a high level of B12 is a risk factor for whether ischemic heart disease or diabetes, no.
Okay. And one more question about the risk factor. Can we consider hyperuricemia over 600 or equal or persistent or patient on immunosuppressive treatment as a cardiovascular risk?
No, it's not part of the cardiovascular risk. The cardiovascular risk is basically what increases the risk of cardiovascular disease, which is smoking, hypertension, diabetes, and other risk factors might include chronic kidney disease and evidence of albuminuria and advanced retinopathy.
Okay. Thank you, Dr. Ala. For Dr. Mohammed Farouqi, they were asking the maximum dose of metformin is 2,000, and some endocrinologists prescribing 2,500 to 2,750 with good EGFR. Is the efficacy is the same?
Pretty much once you kind of reach the level of 2,000 in a day, beyond that, you're not going to get any significant incremental effect. So it all depends on how the treating physician is seeing and what response he's getting. But generally, 2,000 is the pretty much the most efficacious dose.
Okay, thank you. There is one more question. I don't know if you will ask it. Will answer it, Dr. Mohammed. It's about type 2 diabetes with hypercholesterolemia and CK level is 173, and he's asymptomatic. We can offer him statin.
So, I mean, if you just take the example of the NICE guidelines, it clearly states that if you are more than 5 times the upper limit of normal, you would be better off not starting a statin.
Again, back to Dr. Ala, how to calculate the cardiovascular risk?
There are many cardiovascular risk calculators available, and we discussed it that day that none of them has been actually validated for our population. However, if we can use the ASCV, what do you call it? Yes, atherosclerotic cardiovascular disease, ASCV cardiovascular risk calculator. Some people do use the Framingham, but I think the ASCV is more compatible with our population than other risk factors.
Thank you. Now the question is to Dr. Madani. Do you think a new diabetes management solution based on real data to improve patient adherence to the treatment?
Well, adherence to the treatment is very important if you want to achieve your target. And if patients are not controlled or don't achieve the target on oral glycemic alone, we have to convince the patient to take the injections, either GLP-1 receptor agonist or insulin, and to intensify the insulin if we did not achieve our goal. This is something we have to convince our patient and, make them get rid of the fear they have from the injections.
I think they are asking similar to the question, how can we easily communicate to the patient to plan to titrate the pre-mixed insulin?
Well, the pre-mixed insulin can be used if you are going to take, 2 injections, although the risk will be higher in pre-mixed insulin rather than taking the basal bolus doses. You know, I personally prefer the basal bolus doses than the premix insulin, but the premix insulin can make the number of injections less. And so patients who can be controlled with 2 doses of premix insulin, that will be, you know, something good rather than taking more injections.
One more question, Dr. Madani. If the patient is afraid of hypoglycemia, why not to combine GLP-1 analog instead of adding preprandial insulin?
Well, you know, if it can be done, you know, I never tried that, and I didn't hear, you know, any study that can show the GLP-1 with the preprandial, you know, because the aim is first to control the fasting glucose, and that we achieve it only with the basal insulin at the bedtime. Once we control the fasting, which is, as I said, between 110 and 140, then it will be easier to control the other, you know, readings. So if we take the preprandial and GLP-1, I don't think that we can achieve a good fasting glucose control.
One last question for you, Dr. Madani. What is the maximum basal dose before starting mealtime insulin? And what is the maximum dose of insulin per kg body weight which can be given?
Well, for the maximum dose of you know, basal insulin alone, if you reach something to 50 units per day and you did not achieve a good you know, glycemic control, I think that will be a maximum. Then we have to add the preprandial doses to that. And the total dose of insulin, we are starting, as you say, for the premix, we start with the 4 units, or we can say 10% of the total dose in the morning before breakfast, and 10% of the total dose before the lunch, and 5% of the total dose before the dinner. This is, you know, the way we start. And there is no limit for the maximum dose of insulin. We can give the insulin as much as, you know, the patient requires.
Thank you, Dr. Madani. Dr. Ala, what about tolerability-based concept? Based on what?
Again, sorry, your question?
What about tolerability-based concept? I don't know.
Tolerability-based concept. I'm not sure of the concept, but I understand that they mean whether patients, whether they tolerate the medications or not.
Maybe, because it's not a clear question.
Yeah, so it's very essential to look at the side effects of medications when you start it. And I focused basically in my presentation, because it's a high risk and very high risk groups, I focused on SGLT2 and GLP-1. So if I'm talking about tolerability for GLP-1, it's basically the side effects. There are specific advices that you need to give to patients when they're starting the GLP-1. The most important is you start with a small dose and you start increasing your dose as you go. For liraglutide, for example, we start with 0.6 for 1 week or 10 days, and then you increase it to 1.2, and then you increase to 1.8. I usually advise patients, if you start 0.6 and your symptoms disappear, the nausea and vomiting, and then you want to increase to 1.2, then if you started having nausea and vomiting again on 1.2, then go back to 0.6 for a bit longer time, and then you increase later to 1.2 until you reach 1.8. This is one. Second is I advise them to eat half of what they have been eating, half of your portion that you used to eat previously. When you start GLP-1, try to eat half of your portion that you've been eating before to reduce the risk of nausea and vomiting. And the third is I advise them to drink enough fluids because they will reduce their fluid intake when they start these medications. That usually reduce the side effects of nausea and vomiting. It wouldn't disappear completely. With regard to SGLT2, there is no specific recommendation. It's mostly the genital infection. So advice usually the personal hygiene and drinking enough fluids. I tell them usually you might have an extra void of urine per day. And if they develop urinary tract infection and repeated genital infections, then I have to stop these medications. However, in most of the studies, the risk of discontinuation due to side effects is not very high. It's usually very low, and these are generally tolerable medications, but not as tolerable as, for example, DPP-4 inhibitors. They do have side effects, but they are tolerable, and you always look at the benefits of these medications.
Thank you, Dr. Ala. I think also if we explain to the patient from the beginning the tolerability and the side effect, it will make it more acceptable for the patient to tolerate
Absolutely.
it and to manage the side effects. Now the question is for Professor Lawrence. They are asking about the oral semaglutide. It had 3-point reduction of MAC or not?
Right. So I understand oral semaglutide is not yet approved, but it's in your country. It has been recently approved in Canada and is available in the United States. In the Pioneer 6 trial, MACE was reduced, but not significantly. But again, it was limited by the fact that they're limited, smaller study than most of the others, fewer events. So the magnitude of the risk reduction was similar to what we've seen with the other drugs, but it did not reach statistical significance.
One more question is why not to combine both SGLT2 and SGLT1? And if there is any study on that?
Yeah, so very, very important question. Answering the second question first, no, there are no completed trials combining the two classes, nor to the best of my knowledge is such a study underway. I believe, however, that likely the benefits are additive. We know that the drugs have different mechanisms of action for cardiovascular benefit. We know that, for example, in the GLP-1 RA trials, the benefit was similar if patients were on SGLT2 inhibitors or not. And in the SGLT2 inhibitor trials, the benefits were similar whether patients were on a GLP-1 receptor agonist or not. So we do not have definitive evidence, but if cost or access is not a problem, this is certainly something I do frequently in my practice.
Thank you, Professor. Dr. Madani again, if the patient, اليوم قلب الأسد دكتور عندك كل الأسئلة. If the patient is on hemodialysis, can be shifted back to oral hypoglycemic monotherapy after the insulin injection?
Well, patients on the dialysis, it means that they have a poor renal function. They have reached to stage 5 renal function. And for these patients, if you give them some of the oral therapies may be risky. Like, for example, the metformin is risky for this patient. And also sulfonylurea carries also a high risk. The same thing with the TCD. In this stage, I prefer to keep the patient on insulin. You know, it will be more protective for his kidneys than any other oral medications.
Thank you, Dr. Madani. For Dr. Faruqi, what the other option for treating albuminuria in patients intolerant to both AC inhibitors and ARBs?
So the data basically is with both ACE inhibitors and ARBs. So if we cannot use any of those, then the focus will remain on getting as good a blood glucose control as you can possibly do, control the blood pressure otherwise, plus the fact that you have to limit the amount of protein in the diet. So pretty much 1 gram per kilogram is what you should be looking for. But basically, those are the options that you have.
One more question, Dr. Faruqi. Metformin XR 750 or 500 and increase the risk of cancer. What is your opinion?
I have not seen any study that shows that metformin has increased the risk of cancer in any population. In fact, there is some evidence to show that it may help in colon cancer. So yes, I mean, if it is regarding the press reports that are there in terms of the NMDA, which is kind of something that showed up in certain packaging. I think if Larry can comment on that, I think one of the companies was in Canada and most recently another company in India showed up, some trace amounts of NMDA, but I am not sure, even I don't think anybody's sure that how that is showing up. Either that's something in the where the packaging was done or whatever the cause may be. But right now, no, I don't think that there is any risk of any enhanced cancer in any segment of population.
Thank you, Dr. Farouqi. Again, Dr. Madani, there is patient using Jonamine 50 over 1000 milligram and pre-mixture 38 units in morning and 12 units in evening. After 3 months, hemoglobin A1C 8.5. The age is 55, the weight is 75, and patient have insulin resistant. The question is what's preferred, to add basal insulin or pioglitazone?
Well, he is taking 2 doses of premixed insulin. And in addition to the metformin, I believe that you said, and but still his blood sugar is not at the target. In this case, we prefer, to keep him on the basal bolus doses to control his blood sugar better and to achieve a better glycemic target. Metformin, we can keep it if you feel that he's having some sort of insulin resistance. Metformin may help in this case. But the TCDs, I don't think it will be advisable at this stage.
And how you shift from pre-mixed insulin to basal or bolus insulin?
Well, if by 2 doses, actually the aim of pre-mixed insulin to give the patient, less number of injection. But if he's not controlled on taking 2 doses, some doctors go for 3 doses. I personally don't. I feel if the patient needs more insulin, then better to go to the basal bolus, which you can, titrate it much better and bring it more under control rather than the premixed insulin.
Yeah, thank you, Dr. Madani. Again, for Dr. Sarah, they are asking about the pneumococcal vaccine, the PCV23. Is it 2 doses before this age of 64 or after, and if it is for every 5 years? Dr. Sarah?
Sorry, I was talking to myself. It is 2 doses below the age of 64, 5 years apart. And then if they've only had 1 dose above the age of 65, they need another dose again.
Okay, thank you. Dr. Ala, they are asking about the cardiovascular disease calculator. It doesn't include the ethnic background. Does it affect the cardiovascular disease calculator results?
Yes. This is exactly what I was commenting. And basically, there was a study recently published by a group of cardiologists in United Arab Emirates. It was published in PLOS ONE by Dr. Sharif Bakir and Abdullah Shahab. They tried to look at different cardiovascular risk calculators and try to verify it with our population. There was unfortunately a disagreement, or there is no complete agreement with the actual cardiovascular risk and the results of these calculators. They recommended at the end of their paper that we should develop our own risk calculators because it definitely depends, or it totally depends on as well your racial background. So we do use it, but it might not give us the actual cardiovascular risk for our population. I give you an example. The SCORE risk calculator is developed by the European Society of Cardiology, and they basically say it has to be used only for people with European background or Caucasian descent. It shouldn't be used for other races. So to summarize this, we do use the cardiovascular risk calculators. However, it might not give the actual risk score for our population. We need to develop our own risk calculators.
Okay, I think we have reached our time. We have to wrap our session. So at the end, I'd like to thank all our valuable speakers, the local and the international. I'd like to thank Dr. Sarah, Dr. Aladdin, Dr. Mohammed Farouqi, Dr. Madani, and Professor Litter for this valuable and scientific meeting. And I would like to thank our audience. We reached 1,000 audience today. And I would like to ask Nordisk for sponsoring this event. And I hope we'll meet soon in other meetings. Just to remind our audience that the CME will be available within 7 days. Please just fill the evaluation form and answer the post-webinar quiz that will be sent to your registered email ID to obtain the CME credit. And the webinar will be available on demand on Emirates Diabetes Society website and also on the YouTube channel. And we are waiting to see you in our 2 next webinars. It's the Young Leader Forum. The first one will be on clinical perils in the management of diabetes from the elderly and DKA and the pump on 18th of November. The second one will be on diagnostic and therapeutic approach of adrenal disease on 9th of December. Thank you again and have a nice evening and a safe evening, all of you. Thank you.